I'm surprised they let you leave.
Oh, no, I'm just trying to show space.
Good afternoon. It's my great pleasure to introduce Petra Wilder-Smith, who's a doctor of dentistry and also a PhD. Dr. Smith is professor and director of dentistry at the University of California, Irvine's Beckman Laser Institute. She's a fellow of the University of California, Irvine's Comprehensive Cancer Center, visiting professor at Aachen University, and visiting lecturer at Loma Linda University. Dr. Smith obtained her dental degree with honors and distinction from the Guy's Hospital in London in 1983. In 1985, she was awarded a doctorate, summa cum laude, from Bern University in Switzerland, gained oral medicine specialty certification during 5 years as junior faculty at Heidelberg University in Germany. She was awarded the Research Prize of the European Endodontic Society, okay, I didn't say that right, in 1987. Best Clinician Award, Heidelberg University, 1988. And she obtained the International Stauffenberg Award for Innovative Research and the Best Lecturer Award at Heidelberg University, both in 1989. In 1999, Wilder-Smith was awarded with summa cum laude doctorate on the topic of optical diagnostics in the oral cavity from Aachen University in Germany, and which is one of the leading institutes in Europe combining optics and lasers with dentistry. Professor Wilder-Smith's interests include the use of non-invasive optical techniques such as fluorescence and OCT for oral diagnosis, especially in the early detection and monitoring of precancerous and cancerous changes in the mouth. Her work in this field over the past 15 years has resulted in many collaborations and more than 100 publications. It's my pleasure to introduce Dr. Wilder-Smith.
Thank you so much for your kind introduction, Dr. Milster. Well, it's a pleasure to be here with you this afternoon. Can you all hear me? All right. Let me know if my voice drops too low, please. You have a beautiful facility here. Last time I came to Tucson, which was my first visit, I was staying the other end of the campus, and I just went from there to the College of Optical Science. I never saw your beautiful quad, or I think mall as you call it. I never saw the beautiful buildings around here, and I had no idea what a gorgeous place this was. It's truly a lovely place to visit, and I'm glad to have been able to see it. So why am I here today? Not only to admire the architecture and the landscaping here, but to talk to you about a wonderful ride, a wonderful career that I've had and continue to have, that all started with the words, there must be a better way of doing this. I think we've all had experiences like this, just in everyday life, where we suddenly are pulled out of the acceptance of the norm and we go, really? Is that what they're going to do? Is that the best they can do? This time, in this era of this world, we've come up with nothing better. Well, I studied dentistry in London, but I have to make a confession. In Europe, you study dentistry and medicine. You start as an undergrad. I'd never had dental treatment. I had no idea what a dentist did. I studied dentistry in London because my best friend was a year older. And she was studying dentistry in London, and I loved London. I thought it was wonderful. And I loved going up to visit her, so I thought this is what I shall do as well. And the first 2 years were marvelous. You do all the basic sciences, the physiology, the pharmacology, the biochemistry. I loved it. Third year came around, clinical time. So of course we're excited. We're going to be seeing dentists. We're going to be seeing patients. So you put on your white coat, and you feel so proud because now you're going in there as a real professional. And suddenly I realized, this is what I'm going to be doing? And the day, I remember so well the day when this thing came into my life, there must be a better way. I had a patient who was an elderly lady who complained of a burning tongue, a very sore mouth. And I looked in her mouth. And of course, I didn't really know what I was looking for. I looked to the best of my limited ability, and it looked perfectly normal to me. I went to my supervisor and I said, well, this lady says her mouth is burning. What do I do now? He says, well, did you see any changes? We said, no, not really. He goes, well, she's been sent in by her dentist with a suspicion of oral cancer. So we need to check her out. So I said, well, that's good. Good thing to do. What do I do now? He says, well, you take a biopsy. I'm thinking, all right, that's kind of fun. I'll take a biopsy. Yes, I like this idea. But then I looked in her mouth again, and I didn't know where to biopsy. All looked the same to me, kind of lumpy and bumpy and red and white. So I'm trying to save face in front of my patient. I walk back to the supervisor and go, well, I know how to do a biopsy. I know how to give the injection. I have a little jar I put this biopsy in. But where do I biopsy? So he says, let me come and have a look. Chap comes over and takes a look. He goes, oh, you're right, I see your problem. The problem is that in 60% of patients with symptoms that may be consistent with oral cancer, you see no lesions. So he said, well, just try the highest risk areas. Do one in this cheek, do one in that cheek, do one under the tongue, and do one in the palate. That was when I got to the head shaking stage. There must be a better way. So I did all the biopsies, and they came back negative. So this lady was very happy, and I was very happy, thinking, well, this is over with. And in my supervisor said, oh, no, it's not over with. Now your problem is starting. Because she still has her symptoms. She's a high-risk patient. She's over 60. She's an alcoholic. She is undernourished. She is anemic. She's taking antidepressants. And on top of it all, she's a very heavy smoker. All of the risk factors in one. So now we have to try some other locations and follow her forever. I took some more biopsies. Except she only let me take one. Because she said, listen here, I've already taken 4. And it was very unpleasant. I couldn't eat, I couldn't talk. My lip looks weird now because it's curled up from that hole you cut in there. And you want to do some more. But the results came back good. Why should I let you do any more? So, to what extent are you going to explain to this person who you really don't know very well the level of risk, her background, without offending her? This is difficult. So I picked the 2 next highest risk sites and biopsied those. And indeed, one of them came back pre-malignant. Oh, great. Now I have a diagnosis. Now we'll know what to do, and I can finally move on to another patient. Oh, no, I couldn't. Because pre-malignancy, once you see it in a biopsy, tells you this patient is in a big cohort, a risk to malignant change. But you don't know in individual persons if it's going to change, when it's going to change, how quickly it's going to change. So now I was left with the prospect of informing this lady, who I think by now had lost all confidence in me. She needed to come back every 6 months for the rest of her life for follow-up biopsies. What happened? She didn't come back. Over a 3-year period, 80% of patients biopsied for suspicion of oral cancer do not return. So we have a huge clinical problem. We have 5 to 13% of the population who have potentially pre-malignant lesions. We don't know in whom they will transform. We know neither who is high risk nor who is low risk. And we don't know when this transformation might happen. That was my one, there must be a better way experience. My second there must be a better way experience was I was now in endodontics, having finished my oral medicine rotation for now, doing root canals. And so I was trying to do a root canal on a wisdom tooth, would you believe it, a back molar. So you're trying to get into the back of the mouth, and the idea is to get at this back tooth, drill a hole in it, hopefully anesthetize your patient sufficiently so they don't feel it, and then put these little things in, like needles, into the root canal, And then while the patient is squirming, you hope they're not going to swallow this thing. You hope they're not going to inhale this thing. You hope it doesn't move, because then you have to take an X-ray and see whether all those little pin files are going to the right depth in the tooth, so that then you can start cleaning out and manually filing those root canals before you fill them. It's very, very difficult. And that was my number 2 head shake. There must be a better way. And that's when I decided, after I graduated from dental school, I was going to find a better way. And this decision has led to a wonderful life of meeting many, many interesting experts in all sorts of fields, a huge range of clinical projects, and in many areas, we're finding a better way. So let me tell you about some of them. All right, diagnostic needs in the oral cavity. I just picked out 3. The first one is in dental hard tissues, basically the teeth. Demineralization and decay. The second one is periodontal diagnosis and monitoring, the gums. We all hear about gum disease. How can we tell whether the soft tissues that support our teeth are healthy, whether they have active disease or quiescent disease, and whether they're responding to treatment? Secondly, what about the bones that support our teeth? Are they healthy? Are they diseased? Is the disease progressive? Is it responding to treatment? And the third area is all precancer and cancer, where I've already outlined the problem to you. So let's start with the first one. Optical diagnostics, the first question. Why should we use optics to deal with these questions? Well, if you're cynical, you could say it's because I'm at the Beckman Laser Institute. But actually, I went back and did a PhD specifically in the use of light and lasers for use in the oral cavity, because I was so convinced that this was the way to go. It's non-invasive. You have no incisions, no ionizing radiation. It's patient-friendly. You can repeat it as often as you need. You have no idea what that means to a clinician. How often you miss with your first X-ray, or you miss with your first biopsy, and then you have to go and explain it to the patient, and they think you're no good, or you have to go and tell the insurance, and they won't pay you. And I mean, it's just a nightmare. Secondly, light is very sensitive to minimal changes, changes that maybe can presage clinical change. We can look at cell microanatomy. We can look at expression of molecular biomarkers. We can look at changes in tissue architecture or composition. We can look at chemical changes. What's happening to the bone? Is it resorbing? Are the teeth mineralizing? We can look at changes in vascularity, angiogenesis, an important part of the neoplasia process. We can look at perfusion after a tissue graft. How is the blood flow coming back to those areas? So, many of the properties of light are just ideal for detecting minimal changes, very early changes, for monitoring existing lesions, for looking at small changes in existing lesions, for rapid screening of patients. So, let's look at demineralization and decay for a minute. I know it's really boring. For many years I refused to even do any research on teeth because I was so sick of teeth. But now I got back to teeth, and I found some interesting stuff to do. So, you have a healthy tooth in your mouth. The outside surface is the enamel. It's kind of like the porcelain on your bathtub. It's very dense, 97% mineralized substance. Underneath is a far less mineralized substance called the dentine. It's kind of like bone. It consists of these hollow tubules, mineralized to about 70%. And then in the middle is the pulp, the live part of the tooth with the blood vessels and the nerves. Now, after you eat or drink in the mouth, the bacteria in your mouth metabolize the sugars in the food and cause a rapid drop of pH in the oral cavity. So your pH can go down to as low as 3. Anything below 5.5 causes demineralization of the enamel. And what happens very simply is you lose calcium and phosphate out of the hydroxyapatite, the calcium chloride structure of the enamel. This demineralization in a healthy mouth is very quickly followed by remineralization. So the calcium and fluoride that are stored in the plaque, in the biofilm in your mouth, go into the enamel surface and cause it to remineralize. Alternately, if you have patients who have demineralized lesions, let's say they suck on lemons, they drink too much Coke, or they just have poor buffering capacity of their saliva, you can give them remineralizing mouthwashes that contain calcium, phosphate, and fluorides in the hope of remineralizing these superficial demineralizations. Problem is, yes, you can reverse demineralization very successfully, but you can't see it. So we have a treatment for something that we really can't diagnose. And so a very simple but really important diagnostic question is, I need to know the de- and remineralization status of the teeth so that I can institute very simple, very effective treatment of those lesions and restore the teeth back to health. Now, if you do not treat demineralizations, they do not remineralize, you eventually get bacterial invasion into those porous lesions, and that's when you get caries or decay. Now, caries, too, can be active or quiescent. So, especially in older people, sometimes you'll see these lesions that look brown, and in the olden days we used to run an explorer across them and poke and prod and say, oh, that's soft, I need to drill it out and fill it. Actually, the surface layer of many of those carious lesions is reasonably remineralized so that there is no more progression of the decay. But we have no way of knowing in whom is it active or not. So we don't know whether we need to drill this thing and fill it or whether we can leave it. And if we get it wrong, the tooth is going to decay, the patient's going to need a root canal treatment, which, believe me, is no fun for anyone. All right, so now, this is the part that gets interesting. There is no reason why we should not be able to detect the activity status of demineralization and decay. Look at this. The tooth consists on the surface of hydroxyapatite crystals. The diameter is about 4 to 8 micron. There are little spaces between them. So this here is sound enamel. This here is your enamel crystal, and these are the spaces, the B, between it. When you get demineralization, your crystals shrink a lot, and the space between the crystals gets much bigger. When you get remineralization, the crystals get bigger than they originally were, and the spaces get smaller. So there's no reason why you shouldn't be able to quantify the size of those crystals and the spaces between them. Now, of course, the anatomy of the enamel is a little more complex than that. There's a lot of things going on. But in theory, there's no reason why we can't do this. So we should be working on this. All right. Current diagnostic tools that we have in the mouth. We can do clinical exam. We can do radiographs. There's something called Diagnodent, which works with autofluorescence. There's quantitative light fluorescence, which also works with autofluorescence, and optical coherence tomography. Let's see what we have there. Clinical exam, basically you look at it. Demineralization is very hard to see, so forget it. Remineralization, can't see either. And if you can see caries by the change in color, you can say here is caries, but you cannot say I need to treat this or I don't need to treat this. All right, so let's move on to radiographs. You can take radiographs. You don't see demineralization. You don't see remineralization. You can see decay some of the time, but you're looking at a 3D structure that is complex in 2D. So there's a lot of superimposition of structures. And I'll show you later some radiographs. It's not very accurate. And finally, you have the question of radiation exposure. The Diagnodent is a simple system that was built by Vivo, one of the big dental supply companies, as an adjunct to caries detections. It uses a very simple light source and a handpiece like this. And basically what happens is you have blue light coming out of the end here. It hits the enamel. The enamel has a strong green fluorescence. If it's decayed, that fluorescence is much reduced. And in addition, many karyogenic bacteria have a red fluorescence. So it looks something, oh, come on, like this. Here you're shining the diagonodent into the mouth onto the tooth surface. Visually, this area here maybe has a little divot here, but it's nothing any clinician would pay any attention to. But then look at the fluorescence here. You can see quite clearly a brown spot between all the green fluorescence of the rest of the enamel. The problem is, both with the diagonodent and with the QLF, which is a similar system but tries to quantify the fluorescence, the problem is there are so many confounding factors. There are many reasons why you could see something similar to this. You can have a stain on the tooth. You can have a calculus, residual tartar on the teeth. You can have an area of hypermineralization, so it's actually healthier than the rest of the tooth. That would look very similar. Or if you have some bacteria in the biofilm on the tooth surface that are in that local spot at very high concentration, you'll get red fluorescence from them that looks just the same as this, basically. So it is really not very accurate, and neither system is used very much clinically because it just doesn't add much clinical benefit. You know, if you can't say to someone, I'm 100% certain that this is a lesion, the device is of no use to you, and maybe really doesn't help you. All right. The third option is optical coherence tomography. You probably know more about this than I do. It's basically similar to ultrasound, but you use light. You have a beam, you split it. Half of it goes to a reference mirror. The other half goes to the tissues. You compare the beams that come back to you, and that comparison allows you to generate 2 or 3D images. Here we have some 3D images of extracted teeth. Here is looking down onto a tooth surface. Looks very healthy. Here are 2 little marker holes that we drilled. Looking at the 3D OCT image, the marker holes and the pit, kind of that fissure area in the middle of the tooth, this appearance is consistent with the tooth being healthy. If you look at it from the side, here's a radiograph. This is the position of the pit. You can't see anything, right? You can't tell what's right here because there's too much superimposition. This is the 3D OCT image. Here are your pits at the end of the fissures, and they look perfectly normal. Here's a 2D pull-out image. These pits at the end of the fissures look normal too. If you take a tooth with what may be a demineralized area here, or it may just be a stained area, if you do your 3D OCT image, you see an area of higher reflectivity here and here. It's kind of whitish. If you look at it in the radiograph, here's the pit. You can see no change. If you look close up at the 3D, you can see an area of higher reflectivity here. That's an area of decalcification. For more accuracy, you do a 2D pull-out image, and you can see the decalcification very clearly there. So yes, you see more than with clinical exam or with an X-ray, but you have no idea whether those areas are an old, demineralized area that has become completely stable, or an area of progressive demineralization. You have no idea whether there's early decay in there, early bacterial invasion, and whether that is active or not. So yes, it's an improvement on what we have, but it still does not tell you, is there a need to do anything to this patient or not? Because wherever possible, we don't want to do anything. All right, we then looked at the ability to see decay or demineralization under sealants. Why is that important? It's important because we've found that especially in the elderly, where decay doesn't progress quickly, if we put a sealant over a tooth fissure that has a little bit of not too active decay in it, whatever that means, the decay will stop. But clinicians are scared to do it because they have no way of monitoring whether this now covered lesion is progressing or not, right? So you're not going to cover something that may or may not progress. So here you see a healthy tooth. And let's just look at the 2D OCT image. It's healthy here. And then we put a sealant in. And here you see the OCT image of the sealant. And the underneath the sealant looks healthy. We can see that very clearly there. Now we take a tooth with some demineralization. Image it here. Here you see the 2D pullout image, which is always the best. And you can see very clearly the higher reflectivity in the lesion. We place the sealant. It's seen here in the 2D pullout image, and you can still see the demineralization underneath it. So that's exciting, because it means, at least in patients who are at risk of developing further decay in an early lesion, we can put a sealant over it and monitor whether that lesion is getting bigger or not. We can't look at the lesion and say this is active or not, but we can at least follow it over time and say it's getting worse or not. Okay? So that's some improvement there. And we are currently doing a large clinical trial in seniors in a residential community to compare the effectiveness of putting sealants over early carious lesions versus doing fillings. That's really important because fillings do not adhere well to teeth in the elderly. They fall out all the time. And it's very hard to treat a person who's 82 years old and has trouble swallowing and has a dry mouth and can't hold their head. A sealant takes 10 seconds to place. A good filling takes 20 minutes. It's a big difference in what a patient can tolerate. All right. So the final study I want to talk to you about with regard to demineralization and caries was a really fun one. One of my brothers is a gastroenterologist in Europe, Switzerland, and he gets all the patients from the whole of Western Europe, all the kids who have gastroesophageal reflux. It's a huge problem. These kids have this huge acid coming up into their mouth, especially at night when they're asleep, and it erodes their teeth, and they're often not aware of it. So typically, he will first see them when they already have some damage to their teeth. Now, he's the GI dealing with it, not the dentist, but he partners with a dentist at the local university. And so the question they were asking is, first, how sensitive would OCT in this case be as a tool for detecting gastroesophageal reflux? It would mean you don't have to put a sensor down into the stomach of these kids. You could just image their teeth. And it would probably also tell you how effective are all of these anti-GERD drugs, these proton pump inhibitors, for protecting the teeth. These are kids who by age 14 and 15 are wearing dentures because their teeth are completely destroyed. So it's a big problem. We got a bunch of these new patients in who had not been treated previously, and we imaged their teeth before anything had been done. They'd just been diagnosed with gastroesophageal reflux. So here you see an OCT image, basically just charting the strength of reflectivity coming back off the tooth surface. You're looking down from the surface onto the tooth, into the enamel. Underneath is the dentine. This is the probe sheath. And so this is in a patient who had the reflux, and you can see a stronger reflectivity seen by the red in this patient than you would normally see in teeth. This was a patient who got a placebo drug, no proton pump inhibitor, no acid inhibitor, for 1 month. And then we imaged again. And look at the difference. It's got much worse, right? You're seeing a lot more of the red. So over a period of just 1 month, we could detect an altered level of demineralization of the tooth surface. So that's a high level of sensitivity there for this condition. Down here, you see the results from a patient who got the active protein pump inhibitor. Again, very proton pump inhibitor. Very strong reflectivity signal, as seen by the red here on the enamel surface. And after just 1 month of proton pump inhibitor, you see the tooth has remineralized quite a bit. Its reflectivity is less. We could also measure loss of enamel. And look, in 1 month, they lost this much enamel already. So a very simple tool for measuring not only what's happening to the teeth in these patients, but first for diagnosing a condition and for seeing the overall level in reduction, not only in the mouth, but also in the stomach, because that's where the acid comes from. All right, any questions on that? How long do I have? Half an hour, perfect. Okay. Periodontal diagnosis, I'm just going to talk about very briefly. It's an interesting topic. It's a topic I don't know very much about. So I'm just going to outline the problems and the challenges, and who knows, maybe you'll come up with something. So periodontal diagnosis deals with issues at the interface between the tooth and the gum. The structure is a very complex one. Here's the crown of your tooth. You're looking at a tooth in coronal section now. So here's the enamel of the tooth, here's the root of the tooth, right? And here's the gum around the edge of the tooth. Does that make sense? Okay, so you have the soft tissue of the gum here coming up against the root of the tooth, and then you have these little attachment fibers that connect this uppermost part of the gum to the tooth root surface. This is crucial. These fibers are the strongest attachment that there is between the tooth and the gum. Now, the minute you get inflammation in the gums, infection mediated by bacteria, by biofilm, by trauma, by whatever, the first thing that happens is these fibers get damaged, and you get the formation of a little pocket here. So this becomes a trap for biofilm, for bacteria, and very quickly you get a chronic inflammatory process here that then starts to cause further destruction to the tissues and breakdown of all the fibers connecting the tooth to the soft tissues around the tooth. Underneath these fibers here, the top attachment fibers, is the bone, all right, the socket that holds the tooth in. Initially, the damage from periodontal disease is just to these attachment fibers, but soon the various enzymes that are released through the inflammatory process also start to damage the bone. And you can see this in x-rays. So here you're looking at an x-ray of the back teeth. This is the crown, this is the root, and here's your bone around the tooth, right? So you can kind of see the bone levels between the teeth, but you can't see what's going on here, right? In a patient with moderate bone loss, you'll see maybe something like this. And with severe bone loss, it'll look like this. Now look at this image for a moment. So you can say, yes, this patient has a lot of bone loss. But you can kind of measure it here. You don't really know what's going on here, let alone at the other side. Nor do you really know where exactly the damage is here. So how do we measure this damage? We need to know the damage so we know what to treat. And ideally, we don't just want to know the damage. We want to know whether the inflammatory process causing this damage is still going on or is quiescent right now. We do two very medieval things. We get a probe, and we stick it in this gap, and we measure how deep this pocket is here between the tooth and the soft tissues. Now, imagine you're a patient who has periodontal disease. You've got your act together, you're taking your antibiotics, you're cleaning your teeth, you're flossing them, you're doing whatever you're told to do, and it's just starting to heal. You go back after a month to the periodontist, and what do they do to see if you're responding to treatment? They poke this thing into the recovering soft tissue attachment. So in order to know what's happening, you're causing more damage. But we have no other way of measuring it. So it's absolutely useless at best. In fact, you're causing damage. This is our number one tool. Our number two tool is radiographs, which tells us nothing about disease activity and is extremely inaccurate. Our number three tool, we look at the gums. Do they look pink? Do they look red? Do we see anything coming out of them? Are they maybe a bit swollen? And we have these little indices, 0 to 3 or 0 to 4, that we write down. That's it. That's it. That's all we have. So please, think of something. Now, we tried imaging with optical coherence tomography to see if we could see this interface. It does not work well. This is the only image I ever show. Because it's the only decent image I've ever generated. That's how hard it is. Now, you need to penetrate through the whole of this soft tissue, buccal plate of bone, more soft tissue, to really image this whole area here. And OCT just can't do it. We do not have the penetration depth, nor do we really have the resolution. So yes, I can show you this beautiful image. Look, here is the surface of the tooth. Here are these gingival fibers. Here is the bone. And here is the gingival tissue. I've been doing this for 15 years. It's my only image. The size scales are, the thickness of the soft tissue here is 2 to 3 millimeter. The bony plate will start at 1 millimeter and go to maybe 2 or 3 millimeters. This space is less than a millimeter. The diameter of the fibers, these fibers here are larger. So these fibers here are probably, I don't know, a couple hundred micron. So they're big. Collagen. I know what you're thinking, but you need penetration depth. Okay, and then these fibers are thinner. These are less than 100 microns. All right, so periodontal disease. As the population ages, this is really important because people are wanting to keep their teeth longer and longer, and we don't really have that much decay anymore, so the teeth are okay. Problem is you need to keep your teeth in something, and that in something thing is the problem. All right, any questions on that? All right, let's move on to oral cancer. Oral cancer results in more than 150,000 new cases in the U.S. and more than 10,000 U.S. deaths annually. Now, I always write in my grant proposals, that's more than cervical cancer and ovarian cancer and testicular cancer and prostate, I don't know, a bunch of really, really popular cancers, just to say, look, this is a big deal. It's more than all of them put together. It's the fifth greatest cause of death by cancer in the U.S. In other countries, it's much worse. In many parts in India, it's the #1 cause of death, not just by cancer, by anything, especially in women, which is unheard of. So it's a big deal. And now we have this epidemic of HPV. We used to see oral cancer in people over 60 who were living on the street, exposed to too much sunshine, drank too much alcohol, who were undernourished, smoked. You get the idea. We knew our risk groups. My children's orthodontist is 28. She's a marathon runner. She's one of the healthiest people I probably know. She just lost half of her tongue to oral cancer. It's no longer a disease of the old and the marginalized. It's a disease of young, healthy people, which means not only do we need to treat a totally different cohort of people, we need to make that treatment last much longer. Because these people have a longer projected lifespan, and because cancer tends to progress more quickly the younger you are. So it's become the problem of everyone. So the interesting thing is, if we detect oral cancer early, before it's metastasized, the 5-year survival rate is over 80% now. I wrote this a few years ago, and I saw it's over 80% now. So it's very good, and we can treat it pretty well. In more than 2/3 of patients, we detect it when it's metastasized. There's a lot of blood supply and lymph supply to the head and neck, so oral cancer metastasizes quickly and extensively. So in patients where it's metastasized, your survival rate, 15%. Over 5 years. And 2/3 of all cancers are detected when they've metastasized. Yet, 60% of people with oral cancer had visible lesions in the oral cavity that were being monitored. But what's monitoring? Look at this for a minute. All right. 2 of those are oral cancers that took the lives of the patients. 2 of those are totally harmless conditions. Can you tell me which is which? No, I couldn't even tell you which is which, except I know these slides. Visual diagnosis of oral cancer is as good as flipping a coin. You cannot diagnose oral cancer by looking at lesions. And so if you can't diagnose it by looking, how do you screen? So we need more than just a diagnostic tool. We need a screening tool. All right. What is oral cancer? In oral cancer, in a healthy patient, when you're looking down at the oral mucosa, you have your surface keratinized layer, the tough, thick layer on the surface of the mucosa that allows you to eat without shredding your mouth. You have the underlying layers of the epithelium, the basement membrane that separates the epithelium from the underlying connective tissues. When you get dysplasia, potential premalignancy, that surface epithelium has changed quite a bit. You have a lot more keratinization, a lot more fibrous dead tissue. And the bottom layer, the basal layer of the epithelium, has started growing down into the underlying tissues. But there is still a clear basement membrane demarcation between epithelial and subepithelial tissues. An advanced dysplasia, where you're starting to think, oh, this is not good, looks like this. You have lots of down-growing fingers, meaty pegs, they're called, of the epithelium, but you still see basement membrane. Here, you're starting to see a breakdown of the basement membrane. See here how there's really no delineation anymore, or here. So this is starting to invade, and this is an invasive squamous cell carcinoma. Why do I show you that? I show you that because 15% of the population at any time has this or this. 3% of the population has this. In none of these patients can we say, we need to resect your tongue. We need to take out half of your cheek. Because some of these lesions will stay there forever and never do anything. And some of these lesions will take a patient's life. But our only option is to biopsy them every 6 months, and patients don't come back. All right. India has one of the highest age-adjusted rates of head and neck cancers. It's the most common cancer there. It's 40% of all cancers overall. In some parts of the country, it's 50%. We have some unusual risk factors there. We have betel nut chewing. We have a poor diet. We have something called reverse smoking. First time I went there, I was really fascinated to see people light a cigarette. And then you know what they do? Often they're filter cigarettes because that's good for you. It's healthier, right? So to avoid the filter and to get more of a kick out of the cigarette, they turn it around. And they put the lit end in their mouth and they inhale it. And the minute you put the lit end in your mouth, not only do you get all of the mutagenic effects of the tobacco smoke itself, but the heat increases the vascularity in the mouth and causes increased permeability of the oral mucosa. So you're hugely increasing the cancerization effects of the smoking by doing that. When you go to India, you'll see young people walking around like this. And yet the interesting thing is, in some areas they have better public health programs than we do. For example, in the Bangalore region, they have these low-level healthcare workers. People have third-grade level education, and they're equipped with cell phones, wireless connectivity, and they go from village to village. And every 6 months, they see the same people. And they have a questionnaire that they ask them. They fill it out, and they take photos, and they send those photos to the cancer center. And in that way, they attempt to screen for risk of GI cancer, for heart disease, for oral cancer, or whatever. So the wonderful thing is you have wireless connectivity across huge swathes of India. One summer, I sent out a group of 12 of my students just to plot the signal all over India, because I had a plan. And they all have smartphones. And they all have this wonderful patient database that is in a central repository where data gets updated every 6 months. So there's an infrastructure there that we don't even have. But there's no diagnostic capability there. So we have in India a very, very simple OCT device now that these people use. It's very robust and works off solar power. And we use it for these basic level healthcare workers to image the mouth of each of their patients. They just take 6 shots, upload them, goes via a Drobel system to us. And we have a very simple diagnostic algorithm that shoots straight back to my colleague in Bangalore. This, and this patient needs to be contacted by the field worker and sent in. So there's a lot we can do if we just figure out what infrastructure is already there. Because screening is expensive and it's hard. But most communities have some kind of an infrastructure, be it a church, be it a public health clinic, be it a child care, be it an elder care facility. And I think one thing we have to do is really focus on using what's there. We can't keep starting from scratch. So this India program is a very exciting one for me. So let's look at some optical approaches for detecting oral dysplasia and malignancy. One option is to do spectroscopy. We can look at all sorts of changes in the tissue. We can look at changes in cell morphology using reflectance. We can look at changes in fluorescence, which will tell us about cell metabolism or various chromophores. We can look at Raman for tissue chemistry. We can look at elastic scattering properties for looking at very high-level architectural changes. So there are lots of spectroscopy things we can do, and there are various devices out there that do this. The challenge is that during any process of neoplasia, there's so many changes going on. The problem isn't too little information. When you do spectroscopy, you're drowning in information, and you're trying to figure out, okay, which are my simple yes-no parameters that are going to really give me something of clinical use? So when I was first at UC Irvine, I was totally green, and for some reason, I got an NIH grant. I was appalled. Now I had to do something, and I really didn't know what to do with this thing. All right, so I said I was going to use autofluorescence to detect pre-malignancy and malignancy using the hamster cheek pouch model. So, all right, it's really hard to do this. I'd never really worked with animals. I didn't really want to work with animals. I didn't know much about spectroscopy, so I thought, I will do a pilot study. I will get one animal, and I will follow it over time, and I will see what happens. And we got this wonderful chart. Look, we followed the animal over time when it was healthy, when it had a moderate dysplasia and a squamous cell carcinoma, and we looked at various wavelengths of excitation and emission. And lo and behold, at these parameters, we saw a clear trend of decreasing fluorescence, as we did at most wavelengths, except we saw the opposite for porphyrin fluorescence, which increased with increasing pathology. I thought, this is easy. I don't know why no one else can do this. I can do this. I don't even know what I'm doing. What didn't I realize? I didn't realize we had a baseline. We had one animal that we'd imaged when it was healthy. One of the biggest challenges when you're doing anything to do with cancer is you don't usually have a baseline. And in the mouth, for example, you have 6 different types of tissues. You usually have some form of infection in there from periodontal disease. Maybe you have a fungal infection as well. And all these things change your spectroscopy data so much that you have no chance of detecting dysplasia or malignancy in a patient whom you have not followed in one specific location since the day they were born. It just doesn't work. So it works wonderfully in the lab, but don't try and do it in patients. Okay, there are actually various clinical modalities based on autofluorescence imaging. And to be fair, these modalities really tried to narrow down the options. So typically when you develop cancer, you get more and more red fluorescence, less and less green fluorescence. So there was a system built a while ago called the LIFE system for looking at the lungs. Here you're scoping the lungs. Typically you see a strong green fluorescence in the lungs. In the area of malignancy, you see a dark patch. It was adapted for the oral cavity for the Veldscope system, which uses the same idea. You use blue excitation light. You can have less green fluorescence and more reddish-brown fluorescence with the development and progression of malignancy. So here you see with the Veldscope system a healthy tongue, looks like this, a tongue with a white lesion here that shows up as a dark patch here. Very nice. What's the problem? Most people have periodontal disease. Inflammation looks exactly the same in the mouth, as do some areas of scar tissue. So, I think 95% of the adult population have at least one area of periodontal disease in their mouth. So, in patients where you know they have a premalignant lesion that's previously been diagnosed by biopsy, you can monitor them pretty well using this system. But it's no good as a screening tool because there are too many confounding factors in the oral cavity. There's another approach called the Visalite system that uses a very primitive form of chemiluminescence. Same thing. You use chemiluminescence as your light source, and the idea is you get less fluorescence in areas of malignancy. This dark patch here is an area of squamous cell carcinoma. I've been doing this for many, many years, and it's just very difficult to see in the oral cavity. You're holding this stick in there, and then you also need an overhead light because other the mouth is completely dark. Some people are pretty good at using it. I'm not very good at using it, and I certainly think any kind of screening is out of the question. It's just too difficult to use. So, in summary, autofluorescence, is it helpful? It's helpful in some ways, but it's not going to help us as a whole in the general population determine who's at risk and who needs what treatment. All right. So if autofluorescence isn't good, maybe we should develop our own fluorescence. So we can put chemicals in the mouth called photosensitizers. Many of them can be applied topically. They specifically go to areas of premalignancy or malignancy and cause characteristic fluorescence in areas of neoplasia. One photosensitizer we've worked with quite a bit is 5-aminolevulinic acid. It's part of the biosynthetic pathway for hemoglobin in your blood. You put this stuff on, you wait 1 to 3 hours, and then you get a strong red fluorescence of areas of malignancy. Here you see a hamster where we induced cancer. You can see the lesion here, and you can see the strong red fluorescence in this area with the naked eye. We did a clinical trial in collaboration with a friend of mine, Dr. Chen in Taipei, in 30 patients who were referred to us with red or white lesions in the oral cavity. We topically applied photofrin, which is similar to ALA, had the patients wait for 3 hours, and then we did fluorescence imaging. All right, this is what it looked like. So this is in a patient with hyperkeratosis. Let's say their filling was rubbing on their tongue. So it had thickened, but there was no dysplasia or malignancy. Here is the tongue. Here you can see the white patch, and you can see a little bit of red fluorescence. Just ignore the rest for now. Here's in a patient who was diagnosed with premalignancy, dysplasia. Again, you see the tongue, the white patch, and here you see a little bit more red fluorescence, not only here, but also there. This is in a patient with squamous cell carcinoma. The lesion really doesn't look very different from the last one, right? You have a patch here and a patch here. Look at the red fluorescence. It's bright red, and it's not only in the area visible to the naked eye. We're seeing field cancerization here. You're seeing a big patch, here's my thing, up here. You're seeing some malignancy all the way down to there, and some premalignant changes in this area as well, and a big lesion here. ALA works very well for mapping dysplasia and malignancy in the oral cavity. You know what our biggest problem was? Well, we had two big problems. One of them was the FDA, which is why we did it in Taipei. And it was fully approved over there and all the rest of it, but it's very difficult here to get studies like this going. The second problem was the patients had to sit with this gauze soaked in ALA for 3 hours. And the hardest part of the study was we had to hire this bouncer, this very mean-looking gentleman who stood there. And if anyone wanted to smoke, drink a cup of coffee, drink of water, go and talk to their friends or whatever, he was there to stop them doing that. Because patient compliance over 3 hours is no easy thing. All right, so the diagnostic sensitivity of ALA is extremely good. Diagnostic sensitivity was in the low 90%, 90 to 92%. Sensitivity was not as good. That was around 60 to 70%. Why? Again, metabolism is faster, not only in areas of neoplasia, but also in areas of inflammation. So the ability to differentiate between neoplasia and inflammation is poor. So we're still stuck with this problem. Is it malignant, or is it just that they have inflamed gums? Okay, let's talk about optical coherence tomography for mapping oral cancer. Here we did a large study. Oh, sorry, that picture moved. No. We did a large study. We're up to 280 now in patients who came in with red and white lesions. So here's a patient with a white lesion on one side of the tongue. Oh, man, this has slipped right where I don't want it. This is an image of the contralateral side, the other side of the tongue. So you're looking down onto the surface of the tongue, into the tongue with OCT. Surface keratinized layer. Epithelium is this whole thing here. Here's your basement membrane, clearly defined in subepithelial layer. Look at the image we got imaging in this ulcer. All structures disappeared, right? We see no basement membrane. I'm so sorry, this thing moved. There's no basement membrane, no anything. You just see cells going down underneath. So this side was healthy. This is a squamous cell carcinoma, and this is the histology confirming it. Now, we had this big white lesion in the cheek on this side. Looks worse than that, actually. So we took an OCT image again on the contralateral side, surface keratinized layer, basement membrane, clearly defined. And now, look at this image of the lesion here. Surface keratinized layer. Can you see how the basement membrane is growing down? I'm sorry, that's signs over most of it. This was an area of dysplasia, and you can see it in the histology again. We're starting to see some downgrowth of the basement membrane, but no invasion yet. And the diagnostic sensitivities and specificities of OCT in such lesions are around 85%, which is pretty good when you're looking at sensitivity and specificity. As you probably well know, we can do 3D OCT, so we can scan larger volumes of tissue and pick out zones of interest. We can add in doppler so that we can look at blood flow. It's important when we're looking at treatment response or growth of a lesion, because vascularity is one of the first things that changes. And we can scan across the tissues in 2D so that we can just scan across the tongue, for example, and see how it looks. We can add polarimetry for further diagnostic accuracy. And overall, OCT is a very good tool for using in patients with red or white lesions. Disadvantages: it's not that easy to use. There are no commercial diagnostic algorithms available, and it's pretty sensitive. If you drop an OCT system, it's going to be a problem. So it answers many of the clinicians' problems, but logistically, it's not there yet. All right, finally, let's talk about in vivo microscopy. And there are various forms of microscopy. I want to just move down to some of the more interesting images here. This is an important one. So we got some hamsters, and you can induce cancer in them. It takes about 16 weeks. First they develop inflammation, then they get dysplasia, then carcinoma in situ, localized carcinoma, and then full-blown metastasizing carcinoma. Look at these images. These are MPM images, so multiphoton microscopy images. Here you see healthy tissue. You see the collagen fibers perfectly intact, nice network of collagen fibers. After just 1 to 2 weeks of applying carcinogen, you get inflammation. Clinically, it's bright red and swollen. Look at this. You can see a swollen, beautifully congested red blood vessel there in the tissues. And reasonably normal collagen matrix around it. Look at the mild dysplasia. So this is after about 4 weeks, maybe 5 weeks of carcinogenesis. Clinically, I'd look at this patient and goes, well, this doesn't look too bad. Look, the collagen fibers are already shorter compared to here, and they're clumped, and there are voids. Look at a moderate dysplasia. More clumping, even shorter fibers, bigger voids. Severe dysplasia, you're starting to see inflammatory exudates. The day we did this, we were in the lab, and at that time we were working on an inverted system. We had to keep the lab freezing cold so that the laser would work, and we'd come in very early in the morning to do this work. And so our physicist who was helping with the imaging of this, we both looked at it and was like, oh, the system's broken again, you know, black, looks black. So we're so frustrated, and then we looked at it more carefully. It wasn't broken. You see those tiny little red microtumors? And no collagen left. If you scanned across the whole of the tissues, and we were doing tissue areas of about 1 centimeter by centimeter, very laboriously, in half of all that tissue area, the collagen was gone. And the cool thing was, at this stage, you already saw a very clear indicator of change in the tissues. And collagen is easy to image, right? So this is exciting. All right, so we talked about the collagen. There's now an MPT flex system, a system for doing multiphoton microscopy in patients. It's meant to be used in the skin. It's temperamental. It's not easy to use. I want to close with coherent Raman scattering. This is a technology that tells us about the chemistry of the tissues as well as providing us with some wonderful imaging. It's important because it allows us to see very different biomarkers from the other technologies I've talked about. In histology, one of the most important markers of malignant change is change in the shape of the nucleus of the cell and change in the size of the nucleus versus the cytoplasm around the tissues. So here, first of all, we have image of a sebaceous gland and beautiful image of cells around a hair follicle. Now, here we have histology of the cells of the skin. And so this is a conventional H&E stain where we take a biopsy, we section it, we stain it, we look at it. The processing causes the cells to shrink, so you're left with voids around the nuclei in many cases. But if we don't know the actual size of the nucleus and the size of the cytoplasm, we've lost an important diagnostic criterion from this biopsy sample. Look at our images here. You can see the cell nuclei and the demarcation of the boundaries of the cells really nicely. This here is a squamous cell carcinoma of the skin. And you can see these are the keratinocytes, healthy ones. And here you see a stream of atypical keratinocytes invading the underlying tissues. Beautiful image. And here you see the matching histology. And you can see the outline of the cell nuclei and the cells as a whole much, much better than in the histology. Here's another image, squamous cell carcinoma in situ. So it's a localized carcinoma. This is actually what's called a keratin pearl. So in the subepithelial tissues, the keratin from the surface has gone down and then kind of clumped together. And again, look at the detail with which we can see the delineation and structure of that versus the H&E. Here you see SRS images compared with confocal reflectance, which is what is used by many people for trying to look at cells in vivo or even ex vivo. Look here, we can see the nuclei beautifully. We can see the outlines of the cells. Look at this too, nuclei, cell outlines. It's much better than the confocal. And we have much better control about which area of the tissues we're looking at, and we have less damage to the tissues. Here at higher resolution. So many different forms of Raman, I think, provide many potential benefits for imaging in the near future. So in conclusion, what can we say about optical diagnosis in the oral cavity? We know it fulfills every clinician's dream. It's non-invasive. Our patients don't hate us. It's in vivo. We don't have to take biopsies. We can look at many areas of the tissues as we need to because we're not doing anything surgical. It's fast. It's more or less easy to use. We can look at the surface or we can look subsurface. We can look at a wide range of resolution levels. We can look at specific components of the tissue. We can look at the boundaries of lesions and compare what we're seeing visual with whether there's a microinvasion around the visible margins of the tumor or not. We can look at treatment response, structurally or with regard to vascular properties. So there are many, many things we can do. The important thing to keep in mind is, yes, we can build all these really cool things, we can do wonderful things, but we have to keep in mind, in the end, it's the clinical usefulness that counts. And you have to say, is this going to affect the treatment and the outcome of each individual patient? And if your answer in that is yes, then you have fulfilled my dream of truly finding a better way of doing this. Thank you very much.
Thank you very much for a outstanding talk. Do we have any questions from the audience?
Well, I was hoping for a lot more promise on spectral techniques.